Paresh Prabhugaonkar from Pharmafer. On behalf of Pharmafer, I welcome all the eminent faculty and distinguished delegates who have gathered here virtually for this live webinar on follicular lymphoma. I extend my warm welcome to Dr. Brad Kahl, who has been kind enough to spare his valuable time with us today. Dr. Brad will make his intellectual contributions to the content of this webinar today. Also, I'd like to welcome none other than the most celebrated face of hematology in India today, Professor Dr. B Agarwal. Sir needs no introduction. He's an institution in himself. And I now request Professor Dr. B Agarwal to take up the session. Thank you all.
Thank you, Paresh. I'll just share my screen. So, good evening to one and all. Our guest speaker this evening is Dr. Brad Kahl. He will be speaking to us on management of follicular lymphoma in 2021. This webinar is brought to you by Mumbai Hematology Group, supported by Pharmafer and managed by Mice Ideas. I thank Paresh and his team from Pharmafer, Rajesh, Kalpesh and their team from Mice Ideas, Executive Committee of MHG, Dr. Brad Kahl, our guest speaker from US, all the discussants who are eminent hematologists and medical oncologists from India and new participants for sparing your Saturday evening. The discussions today include Dr. Shyam Agarwal from Bhopal, Colonel Dr. Prakash Chitalkar from Indore, Dr. Sandeep Jasuja from Jaipur, Dr. Anupam Jagia from London, Dr. Deepak Charles from Kochi, Dr. Rajashekhar Thirugnanam from Coimbatore, Dr. Priyanka Srivastava from Anand, Dr. Pankaj Tantia from Bikaner, and Dr. Dipti Rani Samanta from Cuttack. It's my pleasure to introduce our guest speaker this evening. Dr. Brad Kahl, MD, is a professor of medicine and director of the lymphoma program at Washington University School of Medicine, St. Louis, US. He earned his medical degree from Tufts University School of Medicine, Boston. He then completed a residency in internal medicine and a fellowship in hematology at the University of Wisconsin. His research focuses on improving outcomes of patients with lymphoma through testing novel agents in well-designed clinical trials. He's chair of the ECOG-ACRIN Lymphoma Committee since 2009, where he has facilitated the development of multiple large clinical trials. He helped successfully renew an ECOG scientific operational grant and led a successful effort to obtain a National Clinical Trials Network Lead Academic Performance Site Award for UW. He is the Washington University Principal Investigator for the LEO Consortium, a large molecular epidemiology effort funded by the NCI. He is a member of several professional societies, including ASH, ASCO, ECOG, ACRIN, US FDA Oncologic Drug Advisory Committee, and NCI Lymphoma Steering Committee. He is a member of the Lymphoma Research Foundation Scientific Advisory Board and served as chair of the LRF Mental Cell Lymphoma Consortium from 2012 to 18. Now it's my pleasure to invite him to deliver his lecture on management of follicular lymphoma in 2021. Over to you, sir.
Well, thank you very much for the kind introduction, and it's really my pleasure to be speaking with you all today. I will share my screen and get my slides up. Can you hear me okay?
Yes.
Okay. And can you see my slides okay?
Yes.
Okay. So today I thought I would talk about management of follicular lymphoma. As I was preparing this talk, I admit there hasn't been a lot of new data in the front line in the last few years, but I will go over some of the data that led to the current standards in management. And then I'll transition to talk about management of relapse disease, where there actually have been a number of new agents that have been developed recently and have received fairly recent approval by the US Food and Drug Administration. You could maybe tell me after the talk, which of these agents are available to you in India, because I don't know that, but hopefully what I'll share with you today is of interest and informative. So just a couple generic words on follicular lymphoma. It's the second most common non-Hodgkin's lymphoma in the United States, with around 16,000 new cases a year. It's really the prototypical low-grade lymphoma. It has generally an indolent clinical course, and the median overall survival probably exceeds 15 years currently. Spontaneous remissions are actually possible in this disease. We generally consider it to be incurable, but I put a question mark behind that statement because it's actually kind of a complicated question and statement, and I think the answer is not perfectly clear. And we'll look at some of that data. The incidence increases with age, and it's most common, median age is around 65. And there is a risk for transformation to diffuse large B-cell lymphoma over time, and that risk is about 2 to 3% per year. So in the bottom right, we see what follicular lymphoma looks like under the microscope. We see expanded follicles in large germinal centers, and this is where the neoplastic cells reside. We ask our pathologist to grade it, and according to the latest WHO classification, grade 1 and 2 are now considered one category, and so that would be if the pathologists see somewhere between 1 and 15 centroblasts, or the large cells per high power field. If there are more than 15 centroblasts, then it's grade 3A, and we would like them to differentiate between grade 3A and 3B. 3A means there are more than 15 centroblasts, but you do see the small cleaved centrocytes, which are really the hallmark of follicular lymphoma. But if the centroblasts are really just forming solid sheets and you're not seeing centrocytes anymore, then it is, but you still have follicular architecture, then it's considered grade 3B. The disease has a characteristic immunophenotype. The cell of origin is a germinal center B lymphocytes, so they're typically CD10 positive and always CD20 positive. And as you know, really the hallmark genetic abnormality is the 14/18 translocation, which occurs in over 80% of cases. So it obviously has to be an early event since it's so common. This results in juxtaposition of the BCL2 gene behind the immunoglobulin heavy chain locus, leading to overexpression of BCL2, which sends a sort of a pro-survival or don't die signal to these cells, which clearly contributes to the pathogenesis of follicular lymphoma. So here's one model of the pathogenesis of follicular lymphoma, and it's believed that this 14/18 translocation is a result of an error in VDJ recombination, may happen in an immature B cell, and then that B cell would be a naive B cell that hasn't encountered antigen, and someday it might encounter antigen and traffic through the germinal center, where it would undergo a typical germinal center reaction and in clones that really are not productive and contributing to the immune response should undergo an apoptotic cell death within the germinal center. But this BCL2 overexpression could provide a pro-survival signal. So these cells, instead of being deleted, actually persist and can exit the germinal center, where they can circulate in the blood as these so-called follicular lymphoma-like cells. And if you just screen healthy blood donors, you will find a proportion of the population that has B lymphocytes with a 14/18 translocation, but they don't have follicular lymphoma. So this is probably a first hit and sort of a precursor to developing the disease. And then later in that cell's lifespan, it would undergo additional genetic alterations that would lead to the development of frank follicular lymphoma. So, you know, what are these secondary events? And here's a nice study that was done from some colleagues of mine at Washington University in St. Louis, where they looked at mutational profiling in over 100 cases of follicular lymphoma. And what they really found were two patterns: a lot of mutations in histone modifying genes, high frequency of KMTD and CREB-BP, and lower but still significant frequency of mutations in EP300 and EZH2. And then there's also a high frequency of mutations in the B-cell receptor pathway genes. And so it's probably mutations in these different pathways that will turn a cell into a frank follicular lymphoma cell. Just a word on outcomes. Most patients have a very good prognosis. You know, it's hard to even know what the median overall survival is for a patient diagnosed in 2021, but it's probably over 15 years. We see some improvement in outcomes over different eras, with outcomes improving, probably due to development of better treatment strategies and novel therapeutics. I mentioned earlier this sort of existential question of whether follicular lymphoma is curable. And, you know, I still don't think we really know the answer. It has this very unusual natural history where patients can relapse after 10 years and 15 years. So it's frankly hard to know if someone is ever cured, frankly. And yet we do see people who are still in their first remission at 10 years and 15 years. And so they might be cured. I'm not sure. One of the interesting things about it is if you follow a population long enough, you start to see the sort of the plateau in the progression-free survival curves around year 8. So a lot of studies, which had followed patients 3, 4, 5 years and kept seeing this drop off in the relapse rate, said, well, see, it's not curable. But if you follow people long enough, you do get a plateau. So maybe there is a proportion of patients that actually are cured with this disease. And I think this is an area that still, frankly, deserves more study and more attention paid to it. Even though the prognosis is very good, I still think it's a difficult diagnosis to receive, especially for younger patients, in their 30s or 40s or 50s. You're not sure if they're really going to get a normal lifespan because of this diagnosis. And so I think there's plenty of room for improvement in our therapies. And when patients do relapse, I'll show you later in the talk that the remissions really are not terribly durable in the relapse refractory setting, and there's lots of room for improvement there. So when you see a new patient in clinic and you're trying to estimate individual patients' prognosis, we have a number of prognostic indices in follicular lymphoma. I tend to like the FLIPI because I can remember it. So if you look at the age, Ann Arbor stage, hemoglobin number, nodal sites, and serum LDH, you can generate 3 risk categories: low, intermediate, and high. And in the original FLIPI study, it predicted overall survival at 5 and 10 years. Now, the criticism of the FLIPI was that it was developed in the pre-rituximab era. And so those investigators went on to develop the so-called FLIPI-2, which was based off patients treated with rituximab chemotherapy combinations. Although the FLIPI-2 just predicts progression-free survival, not overall survival. So I've never liked it quite as much. And then when people went back and retrospectively applied the FLIPI to patients treated with our chemotherapy, it was still prognostic. So I think the FLIPI is still a good tool for estimating prognosis, although I don't think it's the best tool for helping you decide who to treat, because some patients can undergo a watch and wait strategy. The biggest risk factor for death in the FLIPI by hazard ratio was age greater than 60. And so the deaths aren't necessarily deaths due to lymphoma. Those are deaths due to any cause. And so you could have a newly diagnosed patient who's 70 years old, who has widespread small volume lymphadenopathy. So they're going to be high risk because of their age, their stage, and their number of nodal sites. But that's not necessarily a patient you should rush into aggressive treatment. That might be a patient who's best served with watch and wait. So I do think you have to be careful about applying the FLIPI as a tool to decide who requires immediate treatment. I don't think it was really designed for that. There's been a lot of effort to try to incorporate biology into the prognostication. And so there was this entity, the M7 FLIPI. It looks at the mutational status of 7 key genes. And, this could add some discriminatory power based upon the biology. But obviously, this is not something that's easily done in clinical practice. And even this is not that great at predicting overall survival. It's better at predicting progression-free survival. So I think our tools for assigning risk to an individual patient are actually fairly weak. And it's when you have a newly diagnosed patient, it's very hard to tell if someone is going to have a typical course or an unfavorable course or a highly favorable course at the time of diagnosis. We really don't have tools that help us sort that out very accurately right now. We can look at the tumor grade. We can look at the Guelph criteria, which just is sort of a measure of tumor burden and helps figure out who to treat. And I mentioned the FLIPI-2, the M7 FLIPI. There was even a recent study that looked at gene expression profiling And we're hopeful this would be highly prognostic. And it was prognostic for progression-free survival after R-CHOP, but it still couldn't predict overall survival. So I would argue none of these tools that are applied at diagnosis are as strong as we really need to be to make personalized treatment decisions. So here remains my sort of simplistic approach to managing a new patient. This is like a slide I made 10 years ago, and I keep waiting for it to become obsolete, but it's still relevant, I'm afraid. And I hope I'm still not using it 10 years from now. But when I see a new patient in clinic, I sort of think it along two categories. Do they have symptoms? Yes, no. Is their tumor burden low or is it high? And you can kind of create a 2x2 table. So some patients obviously come in with low tumor burden and no symptoms, and these are the patients we typically will recommend a watch and wait strategy. Occasionally, I have a patient who comes in with low tumor burden, but they have symptoms. Now, sometimes the symptoms are fatigue, and so it's really hard to know if it's really from the lymphoma or some other cause, but maybe they have other symptoms that are more legit, like night sweats or something. And so if you're not sure if the symptoms are due to the lymphoma, you can do a little experiment and try single agent rituximab. But if the symptoms are pretty convincingly from the lymphoma, then probably they're best served with an anti-CD20 and chemotherapy. Occasionally, I have a patient who comes in with high tumor burden but no symptoms. If the tumor burden is not terribly high, you could still watch and wait that patient. You just probably want to watch them closely. Often you will start on an anti-CD20 and chemotherapy with or without maintenance. But to keep the decision-making kind of simple, let's focus on the simplest decision-making scenario where somebody comes in, they're newly diagnosed, they have high tumor burden, they have symptoms. Clearly, it's time to get going on treatment. So then it's typically an anti-CD20. I should update the slide because it doesn't have to be rituximab. It could be obinutuzumab with or without maintenance. So let's look at the data for frontline treatments. A lot of issues to think through when you're picking that treatment. Cure is unlikely, so you have to think about how you want to sequence your treatments in case the patient relapses. Remember, the prognosis is very good, so you don't want to overtreat and create new problems. All these effective treatment strategies can make decision-making a little difficult. You have to factor in patient-specific issues, age and comorbidities. The right treatment for a 78-year-old with a lot of comorbidities might be quite different from the treatment for a 58-year-old who doesn't have those comorbidities. So again, you don't want to overtreat, you don't want to undertreat, you want to sort of get it just right for each individual patient. So in the frontline management, right now, I think the standard is still an anti-CD20 monoclonal antibody plus chemotherapy. We'll go through this data a little bit. It could be rituximab or obinutuzumab. Bendamustine and CHOP chemotherapy are the most commonly used chemotherapy regimens in the US. Maintenance therapy with the anti-CD20, I would say, is optional, and we'll look at that data a little bit. I think it depends a little bit on what induction they get. And there really haven't been any major changes to the frontline management in the last few years. So I'll go through this data kind of quickly. And we'll spend a little more time on the relapse refractory setting, because there have been several new options that have become available in the last few years, including the lenalidomide rituximab regimen. We have a number of PI3 kinase inhibitors, and a fourth one was just approved a couple months ago. We now have a targeted therapy that targets EZH2, tazemetostat, which just received approval last year. We just received approval for a cellular therapy product, a CAR T-cell product. And then there are some, I think, pretty promising investigational treatments, including bispecific monoclonal antibodies. So here's kind of a summary of the trials that led to the current standards in the frontline. So we had the STILL study that was done in Europe over 10 years ago now, and that showed bendamustine rituximab performed better than R-CHOP in frontline follicular lymphoma. And then this North American trial called the BRIGHT study tried to replicate that, and it didn't exactly replicate it. We'll look at those curves, but its BR was just barely better. There's almost a tie. So we should think about why that is, and I'll give you a theory. We had the gallium study published a few years ago in the New England Journal of Medicine, which compared obinutuzumab, also known as Gazyva, so that's the G, compared to rituximab on some different chemotherapy backbones. And it suggests that G is better than R, but I'm not sure it really is, and I'll try to explain why I say that. We had an attempt to try to replace traditional chemotherapy with the relevant study. This compared lenalidomide rituximab to rituximab chemotherapy, and that ended up being a tie. And so lenalidomide rituximab did not get frontline approval in the US, but it does have approval in the relapse setting, and turns out to be a pretty good option there. And then regarding the question of maintenance, we did receive long-term follow-up from the PRIMA trial a few years ago, which is really interesting to look at the long-term outcomes, and we'll spend a second on that. So let's just take a quick deeper dive into the frontline data. Let's say you're going to administer an anti-CD20 in chemotherapy. Which anti-CD20 is preferred? Is it obinutuzumab or rituximab? I think it depends a little bit on what your chemotherapy of choice is. So this was the gallium trial, which you're probably familiar with. Obinutuzumab chemotherapy versus rituximab chemotherapy for 6 cycles, and then responding patients would receive the maintenance anti-CD20 for 2 years. And then the centers would pick the chemotherapy regimen that they were interested in using. It could be bendamustine, it could be CHOP, it could be CVP. So the chemotherapy portion was not randomized. So this was for advanced stage disease with high tumor burden. So here's sort of the top line results from gallium. And obinutuzumab chemotherapy was a little better than our chemotherapy for progression-free survival. There was no difference in overall survival. Here's the 3-year progression-free survival, 80% versus 73%. And it produced a hazard ratio of 0.66, so a 34% reduction in the risk of progression with the obinutuzumab. And the so-called benefit of obinutuzumab seemed to be true no matter which chemotherapy regimen was used. So it held up whether it was bendamustine, whether it was CHOP, or whether it was the CVP chemotherapy backbone. So gallium would suggest that obinutuzumab might be better than rituximab in follicular. We do think obinutuzumab is better than rituximab in CLL, but it's clearly not better in diffuse large B-cell lymphoma based on the Goya study. In follicular lymphoma, gallium shows us that the progression-free survival is better, although there is no overall survival difference. But I can't help but wonder if the positive results of gallium are simply a function of giving more monoclonal antibody. So I did some math and pretended I had a patient who was 2.0 meters squared in body surface area. And if you add up the amount of monoclonal antibody the patient would receive over the 6 cycles of induction and 2 years of maintenance, they're getting 35% more monoclonal antibody, which is pretty darn close to the reduction in the hazard ratio, which was about approximately 35%. So to me, it sort of raises the question, were the positive results just a function of giving more antibody? So to me, it's still not clear obinutuzumab is better than rituximab on a milligram per milligram basis. And I find that a little frustrating to not know that based on the study design. But a lot of folks have concluded obinutuzumab is better, and they're using that preferentially, which is fine. It's clearly not worse. But I do think it's still possible that it isn't better and they're just equivalent on a milligram per milligram basis. We frankly just don't know the answer. So we'll circle back to that, but let's then talk for a second about the chemotherapy backbone. So lots of reasonable options here also. CHOP has been around a long time, CVP, there's fludarabine-based regimens, and we had this trial from our Italian colleagues that compared our CHOP, our CVP, and our fludarabine mitoxantrone in a randomized clinical trial. CHOP and fludarabine mitoxantrone were better than CVP for progression-free survival, and CHOP was better than fludarabine for infection. So coming out of this trial, it seems like CHOP would be the preferred backbone, but this trial obviously did not include bendamustine. So we mentioned a few minutes ago the trials that established bendamustine is a good option. So here's the progression-free survival from the STILL trial. This is the original publication, Kaplan-Meier curves, and you can see a pretty big curve separation, and BR seems to be outperforming R-CHOP pretty handily for progression-free survival. Long-term follow-up was presented at ASCO a few years ago, and the difference was holding up over time, although the long-term follow-up has still not been published as best I can't find it. The BRIGHT trial was published, and then we did get a long-term follow-up a couple years ago. And interestingly, there's not the same difference here. Here's BR in blue, here's R-CHOP or RCVP in red, hardly any difference. Certainly BR isn't inferior, but it's a little always disturbing when you're not getting the same results in two trials. So BR, outperformed R-CHOP and still is almost a tie in BRIGHT. So, what is the truth here? Is BR better, or are they simply the same? So then I think it's worth looking at other data sets to see if we can, sort this out at all. So if we go back to the gallium study, centers would select based upon their preferences. So 60% of the centers chose bendamustine, 30% chose CHOP. And although this wasn't randomized, the two patient populations were quite comparable. Anyway, here are the curves. I just picked the rituximab curves. It would be the same for the obinutuzumab curves. Basically, BR and R-CHOP performed the same, just identical. So again, the STILL results are not replicated. So why is that? I can't help but wonder if there's some impact of maintenance here. So if you go back to the STILL trial, where BR was much better than R-CHOP for progression-free survival, there was no maintenance administered in either arm. And then in the BRIGHT study, where the difference in the two regimens is narrowed considerably, it turns out about half the patients received maintenance because it was left up to the discretion of the treating investigator. So I wonder if in the BRIGHT study that our CHOP curve got pulled up somewhat by the maintenance, and maybe maintenance doesn't pull BR curves up in the same fashion. And then in gallium, everybody gets maintenance. And so again, there's no difference between BR and R-CHOP. So I have this theory that maintenance pulls an R-CHOP curve up, but doesn't have the same benefit for BR, and then negates any difference that you might see. So it's then begs the question about, is doing maintenance after BR really the right thing to do if it's not really substantially improving the progression-free survival? So here's the data from PRIMA for maintenance after R-CHOP, and we had the original publication, and it really pulls our CHOP curve up. I mean, here's R-CHOP in blue without maintenance, and here it is in red with maintenance. It's like a 15-20% difference in absolute terms with significantly better progression-free survival. There is no overall survival difference, so I do think maintenance is optional even in this setting, but there is a big progression-free survival advantage. And we just don't have any randomized clinical trial data testing maintenance R after BR, so this remains kind of controversial. Now, the infections only increased slightly in PRIMA with maintenance, but let's look at the gallium data again, where everybody received maintenance, and this was sort of a concerning thing that came out of gallium. They reported this thing called the fatal adverse event rate. And with Gazyva benda or obinutuzumab benda, 6.8%, shockingly high. Rituximab benda, 5.1%, shockingly high. But in the 1 to 2% range with the CHOP-based regimens. So what happened here? If you really break it down, then the excess fatalities in the benda-treated patients really occurred in maintenance or in follow-up. In maintenance and in follow-up, and it was worse with obinutuzumab. And a really valuable thing that these investigators did is they looked at T-cell subsets. So look at the CD3, CD4 subset after bendamustine. It drops considerably by end of treatment and takes 2 to 3 years to get back to baseline, whereas you don't get that same sort of drop with CHOP or RCVP. So there is significant and prolonged T cell depletion after bendamustine. And so, I suspect that these excess fatal AEs that occurred during maintenance or later after bendamustine are a combination of having prolonged B cell depletion from maintenance combined with prolonged T cell depletion from bendamustine. And that's possibly just a bad combination. So I think it's theoretically possible that even if there is some little benefit for maintenance after BR, it might do more harm than good. I've also seen more neutropenia and things with obinutuzumab. So if I'm using bendamustine, which is still my kind of go-to chemotherapy for frontline follicular because it's effective. If you don't add the maintenance, the toxicity is completely acceptable. There's no neuropathy to worry about. There's no steroid highs and lows. There's no hair loss. It's a very attractive regimen. So I think a reasonable standard in 2021, balancing risk and benefit, would be just 6 cycles of BR, but without maintenance. It's perfectly reasonable to give R-CHOP if people prefer that, and lots do, or O-CHOP. I know investigators who prefer that. And you could give it with maintenance because it does have quite a beneficial effect given with maintenance. Now, I think the COVID-19 pandemic has made us all a lot more leery about maintenance and prolonged B-cell depletion. These patients seem to struggle more with COVID infection. These patients may not be getting full vaccine benefit. So I know we've been a lot less likely to give maintenance at all over the past year in any setting because of COVID. And so I think that's kind of a conversation one has to have with patients and kind of individualize. So there was this attempt to move past traditional chemotherapy in frontline follicular lymphoma. This was the so-called relevance study, which compared lenalidomide rituximab to rituximab chemotherapy. Centers could pick the chemotherapy, either CHOP, CVP, or bendamustine. This was published in the New England Journal of Medicine, and essentially it was a tie. The R-squared performed very well, but it was designed as a superiority study, and it did not achieve superiority. So therefore, the regimen did not get a frontline indication in the United States. Had they designed it as a non-inferiority trial, it probably would have a frontline indication, and then you'd have another option. But it did not get approval. So it is really not a frontline option for us. I just want to say a word about a couple of special situations. Are there times where you may just want to administer single agent rituximab? Well, we know that rituximab works best in low tumor burden. The drug starts to lose efficacy when the lymph nodes get over 5 centimeters. It loses efficacy if the LDH is elevated, if the lymphoma is too proliferative. So I'll consider it when I have elderly, frail patients with comorbidities. Maybe I've started them on watch and wait and their disease is progressing and I just know they're not going to handle chemotherapy very well. So I may not wait until they hit high tumor burden criteria, and I might jump in with single agent rituximab before they get there to keep the disease under control and avoid chemotherapy. Sometimes I have a patient who starts out on watch and wait, but they really struggle with that approach. They don't like it. It's having a negative effect in terms of anxiety and depression. So treating in that situation, I've done at times. Duodenal follicular is a very indolent version of follicular where this may be appropriate if a patient has symptoms. And there is some data for single agent rituximab. This was the UK trial done in low tumor burden patients. The black curve is the patients assigned to observation. The red curve is 4 weekly doses, and the green curve is 4 weekly doses with 4 doses of maintenance. So clearly, some treatment is better than no treatment for progression-free survival, and this kind of just gives you an expectation of how the regimens perform. And then we did a trial in ECOG where we showed it's perfectly reasonable just to use a retreatment strategy rather than a maintenance strategy. You can control the disease just as well, and you end up using a lot less rituximab. Other special situations in the front line. So grade 3B, we think is best managed like diffuse large B-cell lymphoma. Here's data showing how outcomes are without anthracyclines and with anthracyclines. So if I have grade 3B, I would give R-CHOP. Or if the follicular lymphoma presentation seems particularly aggressive, which you sometimes see, the SUVs are quite high on the PET, the LDH is high, the Ki-67 is higher than you would expect. There's bony destruction, there's big effusions. We see this more in young patients where they come in with just this very nasty looking version of follicular lymphoma. Bendamustine does not perform all that well once the cases get to be more proliferative. It's not a very good drug in diffuse large B-cell lymphoma. It's a great drug in mantle cell lymphoma, but it doesn't do very well in proliferative mantle cell lymphoma. So I'd be more likely to use anthracycline-based chemotherapy if I have this kind of situation. Okay, so we'll shift gears and I'll just finish up talking about relapsed follicular lymphoma. Couple considerations. You have to worry or at least consider the possibility of histologic transformation, which is 2 to 3% per year. So consider biopsy if transformation is suspected. And then remember the special category of early progression. So patients who progress within 2 years of frontline immunochemotherapy have a much inferior overall survival, shown in blue here, compared to patients who don't progress. It turns out, if you go biopsy all these early progressors, a substantial proportion of them will be transformed. So I think if you do have early POD, probably worth go getting a biopsy to see if you're dealing with transformation, because that will need to be managed differently. This was a nice study from Brian Link, looking at a big database and looking at outcomes in first-line follicular, second-line, third-line. And so for patients who do relapse, you can see the remissions tend to get a lot shorter. Here's the median progression-free survival, 6 years in the first line, but then 1.5 years, and then less than a year for third, fourth, and fifth line. So it really highlights our need to keep as many people in first remission as possible, and then to come up with better second, third, fourth, fifth line options if you're getting Kaplan-Meier curves that look like this. So when you're dealing with recurrent follicular lymphoma, obviously there are, we have these traditional options. One can go back to chemoimmunotherapy. Let's say you started with R-CHOP, you could use BR in the second line or vice versa. You can do single agent rituximab. External beam radiation works well. Radioimmunotherapy is available. Some patients might be best served by a transplant, either autologous or allogeneic. I was going to focus the rest of my talk on these newer strategies and this new data, just to make sure everybody is aware of what's now available. So here's a summary slide I put together for these different regimens. Now, these patient populations are not all identical, so it's not like a completely fair comparison, but just wanted to get everything on one slide. So here's how lenalidomide rituximab performed in a randomized clinical trial against rituximab. Here's the control arm. These patients had to be rituximab sensitive to be eligible for this trial. So R squared produced an overall response rate of close to 80% with a pretty good CR rate and a median progression-free survival in the 2 to 3 year range, depending upon whether you looked at the investigator or the independent review. Single agent rituximab produced a median progression-free survival of 14 months, which is kind of typical for that drug. We have now 4 PI3 kinase inhibitors approved in the US. Idelalisib, copanlisib, duvelisib, and now umbralisib, all based off of single-arm phase 2 studies. The outcomes are pretty similar, with response rates in the 45 to 60% range. CR rates that are pretty low, median progression-free survivals in the 10 to 11 month range for all of them. There may be some differential toxicity profiles, which I'll talk about in a minute. Another new option is this drug tazemetostat, which is an EZH2 inhibitor. This drug just received FDA approval, and it actually has differential activity on whether your patient is EZH2 mutated, where the response rate comes in at 69%, or they're EZH2 wild type, where the response comes in at 35%. And then a very recent approval was the cellular therapy product, Axicell, CAR T-cell therapy, single arm study, but the response rates are incredibly high with a high CR rate and a median progression-free survival that's not yet been reached. So let's look at this data just a little more closely. Just a word on the R-squared regimen in the relapse setting. So this was the so-called AUGMENT study. This was a phase 3 study of R-squared versus single-agent rituximab in relapse refractory follicular, and it also included marginal zone lymphoma. The patients had to be rituximab sensitive. The treatment was administered for a year. And here's the Kaplan-Meier curve. Pretty big progression-free survival benefit for lenalidomide rituximab over rituximab alone. Higher response rates, more likely to be in remission at 2 and 3 years. And if you separate out the marginal zone patients and just look at follicular, you actually get a small but statistically significant overall survival benefit. This did get an approval and has become a very attractive second-line option in follicular lymphoma. Here's a summary of the 3 more established PI3 kinase inhibitors, idelalisib, duvelisib, and copanlisib. Idelalisib and duvelisib are both oral. Copanlisib is IV. They're both approved to be used in the third-line setting and beyond. The response rate data I mentioned a minute ago. They do have activity. All of them have respectable anti-tumor activity. The problem is the toxicity profile. This class of drugs seems to do something to your regulatory T cells that almost looks like it can give a patient sort of a graft versus host disease without ever getting an allo transplant, because there's significant risk for transaminitis, pneumonitis, and colitis. And these conditions can be fatal if not recognized promptly and addressed adequately. So these can be significant limitations. The risk of pneumonitis and colitis seems to be less with copanlisib than with the 2 oral agents, but there is a significant risk for hyperglycemia and hypertension around the treatment administration. And the IV schedule for copanlisib is a little unfriendly. So these drugs do not get a lot of usage because of these toxicity profiles. But there is this new PI3 kinase inhibitor, umbralisib, which just got its approval in the US in February. This is approved to be used in 4th line and beyond. It's a once-a-day pill. And the efficacy looks comparable to the other PI3 kinase inhibitors, 45% overall response rate, median progression-free survival of 10.6 months. But the colitis and transaminitis and pneumonitis all seemed much less with this agent than what we were used to seeing with the other agents. And this may be the best in class as far as risk-benefit profile. The question is, why would it be better? And here's the chemical structures, and here's the activity against the different PI3 kinase isoforms. And so umbralisib seems to be less likely to affect PI3K alpha, beta, less likely to hit gamma, which might really help this T cell problem that PI3 kinase inhibitors can create. They all hit delta, which they need to do to, kill a B cell. And then they claim the fact that it hits the CK1 epsilon kinase might confer some favorable properties. I don't know if that's true or not, but I think based upon what I'm seeing from this data, if one was to pick a PI3 kinase inhibitor, this might be the one to go for just based on the better side effect profile. So tazemetostat was approved last year. This is this oral drug that is inhibitor of EZH2. EZH2 is is a methyltransferase. So giving the pill inhibits this methyltransferase. About 20% of follicular lymphoma patients will have gain of function mutations in EZH2. So why is that important? Well, if you get back to normal B cell biology, naive B cells that encounter antigen and traffic through the germinal center of the lymph node will undergo upregulation of EZH2, which results in transcriptional repression and will sort of cause those B cells to pause in the germinal center for a while so that they can undergo the appropriate germinal center reaction. And then when it's time to exit the germinal center, EZH2 will downregulate and the cells exit so that you can make plasma cells and memory cells. And so this process is normally regulated and needs to be in balance where you have a certain amount of transcriptional repression by EZH2 and a certain amount of transcriptional activation by other methyltransferases or other histone modifiers. What can happen in follicular lymphoma is patients get this gain of function mutation in EZH2, and this would cause these cells to be to have transcriptional repression all the time, stuck in the germinal center. This probably contributes to lymphoma genesis and lymphoma biology. And this is how the reason why an EZH2 inhibitor could have activity in these mutated patients. Now, why would this drug work at all in an unmutated patient? And the thought is that in those patients, there are loss of function mutations in other epigenetic modifiers like CREB-BP, KMT2D, which again would shift the balance toward transcriptional repression. So again, even though you don't have a gain of function mutation in EZH2, if you inhibit EZH2 with this tazemetostat, you'll bring it back into balance, and you could actually get activity even in EZH2 wild type. So here's the data for tazemetostat. From the single-arm trial, in 45 patients with mutated EZH2, the response rate is 69%, and the median progression-free survival is almost 14 months. But the drug still has some activity in wild-type EZH2, response rate of 35%, and a median progression-free survival of 11 months. What seems to be the beauty of this medicine is the toxicity profile. It's extremely well tolerated. Hardly any grade 3's toxicity ever, hardly any grade 2, frankly. So it's a very attractive medication. It's oral, and it has a very patient-friendly side effect profile. So what about CAR T-cell therapy in follicular? So axicabtagene ciloleucel, or Axi-cel, received its approval in the US just in March. This is for patients with relapsed follicular lymphoma who have received at least 2 lines of prior systemic therapy, including an anti-CD20 and an alkylating agent. This is a CD19-directed CAR T. It's the same product that's approved for use in diffuse large B-cell lymphoma. The approval came off the ZUMA-5 study that enrolled patients with relapsed follicular and marginal zone lymphoma. And they received the typical Axi-cel conditioning regimen and the typical cell dose. And response rates, as I mentioned earlier, are very high with a complete response rate of 80%. Here's the progression-free survival curves. The green curve is marginal zone, so those patients seem to be relapsing, but the blue curve is follicular lymphoma. Now, the follow-up's very short, 12 months, 18 months. So I would say so far so good as far as progression-free survival. But obviously we need longer follow-up to really know how good this treatment is. I'm very hopeful. I'm optimistic and I'm hopeful that this could be a fantastic option in relapsed follicular lymphoma, because it's a one-time treatment. So if this really could produce highly durable remissions in the relapse setting, that would become an incredibly attractive option for certain patients. Now, why do I say certain patients? Well, you still have to worry about the toxicity. There's a significant risk for cytokine release syndrome, significant risk for neurologic toxicity, including grade 3 events. So I think I would limit the use of this to younger, healthier patients, given the risk involved in the toxicity of the CAR T product. I'll just finish up mentioning a couple of novel agents. So I'm pretty intrigued by the data suggesting the bispecific monoclonal antibodies are going to be very good options in follicular lymphoma. Here's one example, mosunetuzumab. This is a bispecific monoclonal antibody that targets CD20 and CD3, so it brings the T cells in proximity to the tumor cells, resulting in cell killing. And here's some data presented at ASH from an ongoing phase 1, phase 2 trial. This is just the follicular lymphoma subset. You can see the response rate nice and high, close to 70%, CR rate 50%. The drug is pretty well tolerated, small risk for CRS, small risk for neurotoxicity, but then once you're past that, which is really just a first cycle thing, then it's just a single dose every 3 weeks. It's pretty easy to give and well tolerated, and it has impressive results. And the other one I wanted to mention are these monoclonal antibodies that target CD47. CD47 is something tumor cells will sometimes put out to block macrophage phagocytosis. It's a sort of a don't eat me signal. So you can give this antibody, which blocks this don't eat me signal, allowing macrophages to do their thing. And so we're getting some data for some of these CD47 blocking agents. And the follicular lymphoma patients are in orange in this waterfall plot. You can see the majority of them are getting nice responses to this other monoclonal antibody that blocks CD47 on tumor cells. So I'm intrigued to see how this class of agents moves forward. So I just put this little graph together on a reasonable approach to management of high tumor burden follicular lymphoma in 2021, focusing on the use of the newer agents. Obviously, these are not the only choices. When I see patients in clinic, first-line therapy, if I don't have a clinical trial, I tend to recommend the bendamustine rituximab option without the maintenance. If I see a patient who's already had first-line treatment with BR a few years ago or R-CHOP, I probably would recommend the R-squared regimen right now, a second line. And now I have 3 brand new options. So if I had a very young, fit patient, I might recommend a CAR T-cell product in the third line. If the patient was older and less fit, maybe tazemetostat based upon its very favorable safety and side effect profile. For patients who relapse after CAR T, you could try tazemetostat if they were young. And then fourth or fifth line, I'd probably save the PI3 kinase inhibitor for after tazemetostat, but umbralisib might be my PI3 kinase inhibitor of choice based upon the safety profile that looks better. Still lots of unknowns in follicular lymphoma. As I mentioned, no great tools for risk stratifying at diagnosis. We're still not sure if we can cure people. Boy, if we knew we could, if you knew you could, if you had a young patient, say 50 years old, and they were low tumor burden, heck, you might as well give them the 6 cycles of BR or their R-CHOP right now and try to eradicate that disease rather than doing the watch and wait strategy. So this is a fundamental question that I would love to know the answer to. We really haven't seen any improvements in frontline strategies now in several years. So, I think we need some strategies trying to improve upon BR, R-CHOP, or other frontline options. And then there's a lot of work to do to sort out the best sequence. This CAR T thing is so new. We don't have long-term follow-up. Where does it fit in? Don't really know yet. I think we're going to have these really attractive bispecific monoclonal antibodies. Where will they fit in? Don't know quite yet. So plenty of work to do over the next several years for follicular lymphoma research. And with that, I will stop the presentation, and I would be happy to take any questions.
Thank you so much, Dr. Brad. That was wonderful. The number of take-home messages, you covered A to Z, everything from the traditional aspect of follicular lymphoma for the fellows right up to the advances that are taking place, and the algorithm that you put forward will be very, very useful to everybody. So we have our Indian colleagues here, and they would like to ask you some question. We also have almost 400 to 500 audience from all over, and they also have started putting up some question. We begin with Dr. Shyam Agarwal. Unmute yourself, Shyam.
Good evening.
Good evening.
Hi.
So, thank you very much, Dr. Brad. It was an excellent expedition of your follicular lymphoma. Thank you very much for educating us. My question is regarding pediatric type of follicular lymphoma in adults. How we pick up and how we evaluate this. And I saw NCCN guidelines also that stage 1, you can excise also the surgery, or ISRT is also a treatment. So I was just wondering, you can highlight this particular type of follicular lymphoma.
That's a good question, and I wish I had a good answer. I've been doing this for over 20 years, and I have never ever seen the pediatric type. So I have no personal experience that I can offer you. So I apologize for just not knowing. I probably don't know any more than you do. Yeah. So if I saw one, I would probably call my pediatrician friends and have them help me on how to manage it. But I have heard that it's a different disease. It has a different biology. It has a different natural history. Yeah. And it sounds like to manage it, less is more. So you can do just surgery or radiation in many cases and spare the patient systemic therapy.
Okay, thank you very much.
Thank you, sir. We'll take one question from the audience. Dr. Krishna Ratham wants to know, what is the status of ibrutinib and venetoclax in the treatment of follicular lymphoma?
Good question. So ibrutinib has been studied, and it is incredibly ineffective. It does not work well in follicular lymphoma. Ibrutinib and BTK inhibitors in general are fantastic in CLL, SLL. They're good in marginal zone, they're good in mantle cell, but they are not very good in follicular. The response rates are about 20%, and they're not very durable. And then interestingly, you would have predicted that venetoclax would be a great drug in follicular lymphoma just based upon the biology, 14-18 translocation, BCL2 overexpression. You'd think venetoclax would be the best drug. It doesn't work very well as a single agent either. Response rates as a single agent for venetoclax are in the 20 to 25% range, and they're not very durable. We are doing studies right now where we're trying venetoclax in combination. For example, we just did a study in our ECOG group of bendamustine in anti-CD20. It was obinutuzumab in this instance, plus venetoclax. And it turns out that combining these things is trickier than you might imagine. I thought this would be a pretty easy combination to execute. We even administered the venetoclax for only 10 days out of each bendamustine cycle so that we could get good count recovery. Even with just 10 days of venetoclax, we had a number of patients struggle with count recovery to try to stay on a 28-day schedule. And then we did see some late infections that were concerning. BK virus, which you shouldn't see except in allotransplantation, and a CMV encephalitis. So this sort of cemented my idea that maintenance anti-CD20 after bendamustine is just not a great idea because we just saw too much toxicity. Now, how much of it is the benda and the obinutuzumab and the venetoclax, and how much of the toxicity was maintenance is hard to know. But I'm just trying to make the point that I am still interested in studying venetoclax in follicular, but it turns out it's a little harder to do these combination studies than we predicted.
Thank you. Dr. Prakash Chitalkar.
Thank you, Dr. Kahl, for an excellent presentation. You alluded to the progression of disease within 24 months, the kind of poor prognostic situation. So do you have any biomarkers like minimal residual disease or BCL2 or mutation burden? Is there any studies to predict who are the early relapsers among the follicular lymphoma?
Yeah. So there was an effort to do this. I didn't include these slides. There was a paper that came out a couple of years ago trying to use that M7 Flippy, which is you can apply at diagnosis, to see how good it is at accurately predicting POD24. And it was mediocre. It still missed too many cases, and it still overcalled too many cases. So the accuracy was just not as good as one would want it to be for clinical decision making. So I thought it was a good effort, but I just don't think it was good enough to use. The gene expression profiling can't predict these POD24s accurately. I think what you're proposing would be, an interesting idea where maybe you treat somebody and then maybe do serial monitoring of blood for MRD by circulating tumor DNA. And there are studies, ongoing right now trying to see if that is going to be a better way to identify the bad actors. And so we just don't have the data yet. Although I would point out that if you adopt that strategy, you're still identifying the bad actors after they've received their first treatment. Yeah. We still, which is better than nothing, but still not as good as knowing at diagnosis who are going to be the really good patients and who are going to be the really bad ones.
Thank you, sir.
Thank you. Take one question from the audience. End of treatment PET scan, if it is positive, it is bad prognostic. What action do you take?
Yeah, so let's say you give someone what you think is good frontline treatment, R-CHOP or BR, which gets 90% of people into remission and about 70% in complete remission, but that still leaves, maybe 3 out of 10 who aren't in complete remission. And you're right, that does predict for a short remission duration. Well, it may be worth getting a biopsy to see if you're sitting on occult transformation. That may be worth doing. And if you are sitting on occult transformation and it was like if you had treated, I just had a patient like this who had gotten 6 cycles of BR at an outside location. End of treatment PET scan was positive, and then they sent the patient into our academic medical center, and I saw her, and we got a biopsy, and there was large cell kind of buried in there all along. So you could transition that patient to R-CHOP right away if they were older. This patient was kind of young and we thought could handle more intensive treatment. So we switched her right to rice chemotherapy and are going to try to do an autologous stem cell transplant if she's chemotherapy sensitive. There's not really good data to tell us what to do here. But so if I have a young patient and I prove it's transformed, and it's still there after frontline treatment, I'll try to go to auto transplant. If it's older, I try to give them R-CHOP. Let's say you do a biopsy and it's just good old follicular lymphoma. It's not transformed. Then what do you do? I might be more inclined to try rituximab maintenance, because sometimes that'll flip people into CR and help the remission duration last longer. Maybe with R squared available now, you might move directly into that. I haven't done that yet, but I could see that happening with that option now available. But I would probably try some approach like that. If after 6 cycles of BR or R-CHOP, they're still not in a complete remission, you biopsy it and it just shows follicular lymphoma, I probably would try to then tack on rituximab maintenance or transition to the R squared regimen. Certainly you could just observe that patient knowing they're not going to get a great first remission, but it would be an opportunity to maybe give that patient a break from therapy for a year or two, maybe. Maybe they need a break. You know, sometimes the treatment's really hard. Maybe that patient we're describing is 78 years old and they just went through 6 months of chemo and they're tired and they just need a break. So sometimes I think you can say, okay, all we got was a PR, partial response. That's as good as we're going to do right now. Let's give you a little break from treatment, watch them closely, kind of get your next treatment in line, but hold off on just jumping right into it. Sometimes that's a better long-term strategy, you know, to not jump in immediately with your next treatment and try to stretch the treatment intervals out a bit. So I will do that too for some patients.
Thank you. Extremely practical answers from your vast experience. Thank you. Dr. Anupama?
Hello, thank you. That was a very nice talk. And I wanted to ask with regards to the CAR T cell patients, of course, you said the younger and the fitter ones. Is there anything else in terms of molecular profiling or disease staging that makes a difference for the patient population selection?
Yeah, well, I don't think we know yet. It was a pretty small study, just like 80 some patients with follicular lymphoma who actually got the CAR T product, and almost everybody responded. You know, the complete response rate was 80%. So I don't think there's enough data yet to know who it's going to work well in and who it's not going to work well in, because in this population, at least in terms of response rate, it worked well in almost everybody. So there's a lot more work to do on the CAR T front. This particular product, this axi-cel, is probably has the highest risk for neurotox and CRS. And I'm expecting that other CAR T products will get approvals in follicular in the next year or two. And these, I think, will have somewhat better safety profiles. And those might become more attractive options even than the axi-cel. So it might just be wishful thinking on my part, because who knows how good CAR T is really going to be. I mean, you probably need 5 years of follow-up before you really know how good this is. I'm hopeful. I'm hoping that it works great. It would be wonderful if this could produce, you know, durable remissions in a substantial proportion of the patients. Obviously, if they've all relapsed by 3 years, then it isn't going to turn out to be that useful. But I'm hopeful that it ends up being a really good option for our patients.
Thank you.
Thank you. We'll take some questions from the audience, and there are a number of questions which I'll put them together. These are all related to transformed lymphoma, and they all are asking whether R-CHOP or DAR epoch or is CAR T straight away possible and approved. So what are the options and which is the best option for a transformed DLBCL?
Right. Some of that depends on what the patient's prior therapies were. It's one of the reasons I like to start with BR, because it allows me to save more options for a potential transformation event. If a patient received, you know, let's say they got R-CHOP frontline 3 years ago, 6 cycles, and now they're relapsing with a transformed disease, well, you've kind of used up your anthracycline, and now your options are more limited. So let's stick with that scenario for a minute. If the patient was, younger and fit enough for an autologous stem cell transplant, that would be our first thought. Okay, let's pretend this patient is 70 years old. For us, that's right on the borderline of who can do auto or not. But let's say it's a healthy 70-year-old. They've already had R-CHOP and now they're transformed. BR doesn't work well. R squared doesn't work well. Your options are much more limited. We would give ICE chemotherapy, and if they were chemotherapy sensitive, we'd probably try to go to autologous stem cell transplant. If we gave them ICE chemotherapy and they showed some chemotherapy resistance, we would try to move towards CAR T. That's what we would do with that scenario. And we've found that the CAR T is a little easier to do on a patient than an auto transplant. So we've done CAR T cell therapy at our center, up to age 85, believe it or not. So you can get older patients through CAR T, patients that you couldn't even consider an auto in. So, if we take that same patient, let's say the patient's 76. They got R-CHOP at age 72, and now they've relapsed and they're transformed. They're probably too old for auto. We can't take them to CAR T in second line because the approval mandates 2 prior lines of therapy. So then we just pick some sort of salvage that we think the patient can tolerate. So for example, I've got a few patients like this right now. I'm just giving them like R-GemOx, which is, not the greatest treatment in the world, but it has a response rate. And we're giving them R-GemOx just to get the disease under control, but we're lining them up for CAR T. Because if they don't go into complete remission, they can go right to CAR T. So I might do like 4 cycles of R-GemOx. Or if they go into complete remission, I'll just watch them super close because I know they're going to relapse. And the second they relapse, we're going to CAR T. So that's what I would do for someone who's sort of used up their anthracycline. If the patient only had BR, they've never had anthracycline, I think you have more options now. You have more choices. And again, I think it'll vary a little bit on the scenario. So I'll just make up a couple. Let's say the patient had BR 4 years ago, got a complete remission, but now they're relapsing. There were some worrisome features. Let's say we get a biopsy and they're transformed. And let's say they're in their 70s. I might just give them R-CHOP. And if they go very easily and quickly into CR on the R-CHOP, I might just stop, like no consolidation, because sometimes that's all you need to do. But if they struggle to get into CR, let's say the response is sluggish, or they're not in CR at the end of the R-CHOP, then you've got to do some kind of consolidation, either a transplant or CAR T. So that one, we sort of take an adaptive approach. But if they just go very easily right back into CR with the R-CHOP, then I may not do any consolidation. Now let's take another scenario. Let's say you gave a patient BR and they relapse a year later with transformed disease. I might still go to R-CHOP, but I'm going to have less confidence in the R-CHOP because they had a very short first remission to the BR. So then I'm much more likely to think about a consolidation strategy like a transplant or a CAR T or something, because now I'm not as optimistic that the R-CHOP is going to do a great job if they got such a short remission to BR. So I know I'm making up some scenarios here, but that's how it is in the real world, right? And you sort of have to factor in all these things. What have they received already, and how well did that work? Because that has a big influence on your subsequent choices.
Thank you. Great answer. Dr. Deepak.
Thank you, sir, for that excellent and lucid talk. My question is also related to transformed follicular lymphoma. So, is there any role for maintenance treatment in patients who have achieved a complete remission and transplant ineligible in transformed lymphoma?
Right. I don't think there's any data telling us what to do there. I can't think of any data in that scenario. Me personally, I have not administered maintenance in the transformed setting. And the reason I haven't is I'm kind of extrapolating from diffuse large B-cell lymphoma, where maintenance was shown to really not be effective. It doesn't really add anything. So I kind of extrapolated from diffuse large B-cell lymphoma. And so when I have a transformed patient who I get into remission, I have never done maintenance, but some of my colleagues do, and I've seen other investigators who do. So I'm admitting that this is kind of an unknown, and you'll get some variation just based upon personal beliefs, but I don't think there's any data to tell us what is right or wrong there.
Thank you, sir.
Thank you, Dr. Deepak. The certain questions related to bone marrow biopsies. With the PET scan around, is there any place for bone marrow biopsies anytime in follicular lymphoma?
That's a toughie. We pretty much have stopped doing marrows in Hodgkin lymphoma and diffuse large B-cell lymphoma, because if the marrow is involved with Hodgkin or involved with large cell, the PET will usually tell you that. So we kind of trust the PET there. Follicular lymphoma won't always show up on the PET, I think. And so as much as I'd like to get rid of bone marrow biopsies, I think if you're doing a clinical trial and you want to make sure your patient's in a CR, you probably still need to do the bone marrow in follicular. But if you're just treating in practice, it's not part of a study, I don't think the bone marrow biopsy is necessary. I don't think it really adds anything to your management. I can understand why some studies mandate it for the sake of the data, but that's just being very academic. I think in practice, bone marrow biopsies are really not necessary in follicular lymphoma, unless your patient has baseline cytopenias and you're not sure why.
One more question from the audience. This is related to the PET scan. A patient who has gone into complete remission and the end of treatment PET scan is normal. In his follow-up, if he's asymptomatic, will you ever place PET scan to pick up relapses?
No. I don't think there's a right or wrong answer here. So I'm just kind of telling you what I do in practice. Once a patient is in complete remission, I don't use PET scans as a surveillance tool. Couple reasons. One is a lot of insurance companies in the United States won't pay for it, so they don't even let us do it. Secondly, I do think the PET scans are perhaps too sensitive. You get too many false positives. So usually once I have a patient who's in complete remission, if I'm doing any imaging at all, it's just a CAT scan, So I typically will do a CAT scan maybe a year after treatment's ended, and then 2 years after treatment is ended. And I might do them yearly for a few years. And then once we've gone a few years, maybe I'll try to go 2 or 3 years between scans. So again, I don't think anybody knows the right answer here. I will do them periodically, as I'll explain to the patient, well, every now and again, we probably should look really hard, but I don't want to look hard too often. So I'll do the scans periodically, but they're just CAT scans, and I try not to do them too often.
Thank you. Dr. Priyanka.
Thank you, Dr. Kahl, for the nice presentation. So continuing on that topic again with the PET scan and imaging on follow-up, my question is, what should be the threshold for treatment in relapse setting, like radiologically, or would you wait for the symptoms to reappear?
If I have a patient who has relapsed, but let's say the relapse was just found on imaging, and the patient feels perfectly fine, and let's say it's just low volume disease, I will try to observe without treatment, because sometimes you can observe for several years. And I like to give the patients the longest treatment-free interval I can give them. And you saw from the slides I showed how short the remissions can last in the relapse setting. So you don't want to burn through your treatments too quickly. I think it's really good to try to stretch them out. So I will try to wait as long as I can before initiating subsequent therapies. Sometimes it's based on symptoms. Sometimes it's just based on the tumor burden. Sometimes the lymph nodes just start to get so big that I'm not comfortable anymore. 5, 7, 10 centimeters. Maybe the patient feels fine, but I'm like, okay, you have a 5 centimeter retroperitoneal lymph node. I'm starting to worry about hydronephrosis. Let's just get going, or something like that. So I don't have a great formula for this. It's more of an intuition thing. But I will try to drag my feet to the next treatment as long as I can. I don't always wait till symptoms occur. I might jump in before symptoms occur if the lymph nodes are getting bulky.
Thank you, Dr. Priyanka.
Thank you, sir.
There's a question from Dr. Sumit. Mantle cell lymphoma and DLBCL both have high proliferative index. Mantle cell lymphoma responds to bendamustine, but DLBCL does not respond. Why?
Well, actually, the initial statement is not exactly correct. Most diffuse large B-cell lymphomas, when you do the Ki-67 stain, the proliferative index is 60, 70, 80%, sometimes 90. So proliferative. An average mantle cell lymphoma, just an average one, the proliferative index is usually in the 15 to 20% range. So garden variety mantle is not that proliferative. In mantle cell lymphoma, anything over 30%, which is a minority of cases, is associated with the worst prognosis. And anything over 50 is very proliferative in mantle cell. So if you have a mantle cell patient with a proliferative index of 50 or 60%, that's very bad in mantle. That does not happen very often, thank goodness. But in cases like that, bendamustine does not work very well in the highly proliferative mantle. So in the instance of highly proliferative mantle, bendamustine does not work that great, just like it doesn't work that great in large cell. But in usual mantle cell, typical mantle cell, where the proliferative index is more like 15%, bendamustine works great.
That's right. Thank you, sir. Dr. Paresh?
Thank you, sir. Dr. Kahl, my question is regarding the scoring system. What kind of scoring system do you prefer in follicular lymphoma cases, like Flippy 1 or Flippy 2 or Prima, whatever you prefer?
I just use the Flippy one. Of all the tools, it's the most robust for predicting overall survival.
Thank you. Again, question from the audience. The question related to allo transplant. Any place left for them?
Well, I'm hoping that CAR T puts allotransplant completely out of business. Obviously, allotransplant is something that we don't use very often in follicular, but occasionally you will. You'll run into a patient who has completely chemotherapy resistant disease. Maybe they're younger and they just don't respond to chemotherapy anymore. Then autotransplant's not a good option for them. And allotransplant can, give you good long-term disease control, but obviously that comes with the risk of chronic graft versus host disease, which is a terrible way to have to live your life. So I'm hoping that CAR T can give us outcomes, at least as good as allotransplant, but without that risk of chronic GVHD. So I envision myself over the next few years really not referring patients for allotransplant and preferentially referring them for CAR T, and hope that CAR T is as good as I think it might be.
Thank you. Dr. Deepti?
Thank you, Dr. Brad, for nice presentation. I want to ask, in this COVID pandemic era, whether you can use R-square regimen in frontline setting, because it is having efficacy of chemoimmunotherapy and no toxicity of chemotherapy. What is your opinion regarding this?
Yeah. Well, I guess the question would be, if a patient received R-squared, if I heard you correctly, you were thinking specifically in the COVID era, and you want to avoid severe COVID disease in your patient, and you want to give them a better chance of responding effectively to vaccines. Is that correct?
Yes.
Right.
The problem with R-squared is one of the R's is rituximab. So, you're still getting prolonged B-cell depletion. And in the frontline relevance, they gave it for 3 years. Or 2.5 years. It's a lot of rituximab. So I'm not sure R-squared is actually going to be any better in terms of COVID than R-CHOP or BR. I don't know. I honestly don't know the answer to that. But there's so much rituximab in R-squared that it might be just as big of a problem. So that's all I can think of it for that answer, is I'm not sure that's any safer. We need some data, I suppose.
Thank you, sir. Thank you, sir.
Yeah.
Again, a question from the audience. He has a patient who has stage 3 follicular lymphoma, and because of the compression of bile duct, there is obstructive jaundice. What is the best way to handle this situation?
Was it stage 3 or grade 3?
Stage 3.
Stage 3. Well, and has the patient received, is this in the relapse setting or frontline treatment?
first line.
Bendamustine is largely cleared by the kidneys. And so I'm thinking that perhaps you can still give BR. I'd have to look that up if you need to do dose adjustments for bendamustine with a high bilirubin. I don't know the answer to that off the top of my head. I would need my pharmacist to help me with that. So my first thought is maybe you can do benda-rituximab. You obviously, given anthracyclines is a problem, given vincristine is a problem, so R-CHOP's not very appealing. You could just do high-dose steroids, just to get a little bit of tumor shrinkage before you come in with chemo. So I might do that. Prednisone 100 milligrams a day or dexamethasone 40 milligrams a day for 4 or 5 days. See if you can get some improvement, see if you can get that bilirubin to come down, and then maybe come in with BR treatment after that. I don't know if, lenalidomide is also mostly renally excreted. So can you give lenalidomide when the bili's high? I think so. But I probably would try high dose steroids, get some improvement, and then treat with BR is what I'm thinking.
Thank you. Dr. Shyam, your second question.
High dose steroids and Rituxan to start with. Should have said that.
Yeah. In this particular case, what audience asked a question of biliary obstruction. Can we not put a stent and then go ahead with the chemo or whatever?
Sure. Yeah, I think it depends how bad the obstruction is. Certainly you could put a stent in. Sometimes the obstructions are so bad. Yeah. And sometimes the steroids that work so good, it's just easier just to get started on some treatment right away. So it's a little hard to know how to answer that one without seeing the scans, see how big the mass is, seeing how bad the obstruction is. But sure, if it could be done technically, that would be an easy fix.
Okay. So my question is there is no overall survival, chances of infections are there. So in a maintenance, nowadays, the trials are looking into the response adopted approach. If the patient is in PR, then only you go ahead with the maintenance of rituximab. Otherwise, if patient is in CR, I think one can avoid the maintenance. What is your take on that?
Yeah, my whole career, or ever since Prima came out, I kind of have been maintenance agnostic. And by that, I mean, I wasn't really pro-maintenance. I wasn't really anti-maintenance. I would kind of discuss it with my patients and see how they felt about it. And we'd kind of individualize it. So some of my patients would get it and some wouldn't, because I just didn't feel that strongly about it. I'd explain to them, it'll make your current remission last longer, but it isn't going to make you live longer. You're going to have to come in here every 2 months to get this infusion. It is going to increase your risk for infections a bit. And some of my patients, they're so worried about relapse, they'd say, no, I want to do the maintenance. And then some patients would be like, well, that doesn't sound worth it to me. Let's not do the maintenance. But I will fully admit that COVID has completely made me rethink this. And this past year, I had a whole bunch of patients sort of in the middle of their maintenance, and I stopped it on everybody. I stopped it on everybody last summer because I was thinking, this isn't worth it. If you get COVID, I'm really worried what's going to happen to you. And I think there's going to be vaccines available in 6 months, and we want you to respond. So I had stopped my maintenance in all my follicular lymphoma patients last summer and into the fall. I had a couple people that were like, no, don't take my maintenance away. And I had to say, you don't want to do this anymore. So everybody's off of it. And going forward, I think I'm really going to avoid maintenance therapy because I think COVID's going to be here to stay for a while, and probably COVID variants, So I think I'm going to avoid maintenance going forward.
Thank you. We have a question from Dr. Radhika. What do you think of bendamustine lenalidomide combination?
Hard to give. A lot of rash. Very, very significant risk for skin toxicity. Again, I've learned some hard lessons these past few years because I actually do like bendamustine a lot in mantle and in follicular, and it's been sort of my go-to for the last 10 years. And I thought it would be kind of easy to combine. Turns out it's not. It's hard to combine with obinutuzumab. It's been hard to combine with venetoclax. People have tried combining it with lenalidomide. The skin toxicity was bad. Bendamustine is proving to be kind of hard to combine. So I don't think combining it with len is worth it. Too much toxicity.
Thank you, sir. Dr. Prakash?
Dr. Kahl, is subcutaneous administration of rituximab prevalent in the United States?
It is. When I had people on maintenance, most of them were getting the sub-Q version. And in follicular, it was kind of easy for me to get rid of the maintenance because there was no overall survival advantage. It's been harder in mantle cell to know what to do because there does seem to be an overall survival benefit for maintenance in mantle cell. So most of my mantle cell patients are still on maintenance, I will admit. And if they're on, if they are getting it as maintenance, they're getting the sub-Q version of it.
Thank you. The question from Dr. Mahesh. If you have a true cut biopsy telling you that this is follicular lymphoma, do you trust it or you can often go wrong?
I would trust it. I think the only danger there, it's really worth it, to look at the PET scan yourself and the SUVs, because sometimes there's a lymph node in the axilla that's really easy to biopsy, and so that's what gets biopsied. And the SUV there is 11. And then there was a retroperitoneal lymph node with an SUV of 21 that nobody wanted to biopsy because it was hard to get to. But I will, make the extra effort to try to go biopsy the hottest lesion if there's some concern, just so I don't miss an occult transformation or a 3B follicular or something like that. But if they biopsied the hottest lesion and the true cut is saying it's follicular 1-2, I trust it.
Thanks. Dr. Anupama?
I was really interested to find out about the PI3K inhibitor erdazalenib, because we here in the UK struggled a lot when we used Ritux and idelalisib, just as you said, with all the side effect profile. So is erdazalenib, is that proving out to be better, as you said?
Which one?
The PI3K inhibitor you mentioned with you, is it erdazalenib?
Umbralisib.
Oh, umbralisib.
Umbralisib, okay. Yeah. So the umbralisib just got its approval like 2 months ago. So I've not had the opportunity to use it yet myself. When I look at the data, it certainly looks better from a safety profile. And I've talked to some of the investigators that participated in the umbralisib trials, and they seem very convinced that it does have a better safety profile. So my current belief is umbralisib will be easier to give than duvelisib and idelalisib.
Thank you.
Yeah. One question from audience, Dr. Chikodi wants to know, what is the place of radiotherapy in treatment of follicular lymphoma?
External beam radiation or radioimmunotherapy like Zevalin? Which one are they asking about?
Radioimmunotherapy we don't have here, so
okay, just radiotherapy. Yeah. Well, radiation treatment works beautifully in follicular lymphoma, and you certainly can take advantage of that because you don't need a very high dose. 24 gray is probably as high as you ever need to go. Sometimes 4 gray will give you a great result. So we do radiation for problem areas. We do radiation for elderly patients who don't tolerate systemic therapies very well. So yeah, I think radiation is a really good option in follicular lymphoma, and I will use it judiciously, but I will use it.
Thank you. Dr. Deepak?
Sir, my question would be, what is the definition of rituximab refractory in follicular lymphoma? And in such a patient on relapse, would you consider any other monoclonal antibodies, anti-CD20 in combination with lenalidomide?
Usually the definition is no response to your most recent rituximab containing therapy or progression within 6 months of a rituximab containing therapy. So yeah, that is a quandary. And what do you do when you have that scenario? It depends on what my other options were, but I would be willing to try like obinutuzumab lenalidomide in a rituximab refractory patient. I'd be willing to try it. There's no data that tells us that obinutuzumab is going to be useful in that setting, but I think it's reasonable to consider. Certainly you could do things that don't have an anti-CD20 like tazemetostat, or lenalidomide is a single agent, I suppose. But I would be willing to try obinutuzumab in combination. I don't know if that works great. I admit it because there's no data, but I think it's worth considering in a patient.
Thank you, sir.
Thank you, Dr. Deepak. The question related to a low volume disease but multiple bone involvement. Will you treat?
Low volume disease with multiple bony sites of involvement. Yeah. So, yeah, I guess one interesting thing is sometimes the PET scan, they call it osseous involvement, osseous, which is, I always complained to them, it's too vague. I can't tell, is it in the marrow or is it destroying bone? That's a big difference to me. And sometimes you can't tell. And I'm not sure in this case what the questioner is referring to, but if it's just marrow involvement, then I would look at, okay, are there cytopenias? Is the patient being affected by it? And then I would sort of think of it like a CLL patient. If you're starting to get cytopenias, well, then we should probably get started on treatment. If they have marrow-only disease and there's no cytopenias, I would be comfortable watching. On the other hand, what if it's bony disease and it actually is bony disease, like the follicular lymphoma is in the skeleton, not in the marrow? I think then you're at risk for pathologic fractures, bony destruction. So I would treat a patient like that right away if there was true bony involvement.
Thank you. Dr. Priyanka.
So do we have any role of interim PET scan in follicular lymphoma? Are we having any case about it?
Yeah. I don't think there's a well-defined role for interim PET because you sort of don't know what to do with the results, I'm afraid. We get it often. And the reason we get it is because, usually I have a baseline PET. And if I want to do some imaging halfway through treatment, I'd love to compare to my baseline scan. So I like to get a PET just because it's easier to compare apples to apples. sometimes the insurance companies will say, interim PET imaging not allowed, Dr. Kahl. So then I have to get a CAT scan. So then I'm comparing a, post cycle 3 CAT scan to a baseline PET, not ideal. And then at the end of treatment, then they will let me get another PET. But let's say you get an interim PET. I think if the interim PET is showing a poor response, well, then, you sort of know your treatment that you're currently giving isn't working that great. And you might want to consider changing it. But, we really don't have great data. I think a scenario I've seen a couple times is a patient who maybe starts on BR, but maybe they had one of these aggressive folliculars, maybe occult transformation in there. And then, there's a PET scan after 3 cycles and there's still some really hot spots on the PET. I don't think you should keep going with BR. I would switch that patient to R-CHOP based on the probability that there's an aggressive clone in there. So, I can think of scenarios where interim PET could change your therapy. Usually it doesn't, but I can think of scenarios where it could.
Thank you.
Thank you, sir.
Thank you. Dr. Pankaj? Okay. Then Dr. Dipti? So I think we are...
Hello, sir. I want to ask, what is your opinion regarding combining obinutuzumab with lenalidomide? Because there is a small center experience in untreated follicular lymphoma patients with high tumor burden.
Yeah, MD Anderson has presented that at meetings, obinutuzumab, lenalidomide in high tumor burden follicular, and the data looked fantastic. So it looks very promising. Unfortunately, it hasn't been compared against anything yet. And it's not approved, so I don't really have that option, but I thought the data looked great. And I'm anxious to see more data about obinutuzumab, lenalidomide in the front line. It could end up being a fantastic regimen. So far, it looks great. We need more data.
Okay, thank you, sir.
We don't have any more questions from the audience. Faculty here has any question? You can just raise your hand. Go ahead. Yasha.
So my question is how you go ahead with the relapse and refractory kind of lymphoma workup? Like you go ahead with the IHC or you do FISH or you do NGS, and how about the MRD assay? Are you into the MRD in follicular?
I've not been doing MRD in follicular, especially in the relapse setting, because to me, MRD is most useful in curable lymphomas.
Yes.
It's, makes a lot of sense. In the incurable diseases, it doesn't make as much sense to me because, if they're not cured, there is disease in there somewhere because they're clearly not cured. So I don't see that much role for MRD in incurable diseases, except in the scenarios where maybe, like if you look at CLL, where they're doing studies where people are on this very prolonged therapy, and you want to ask treatment discontinuation questions, that could make sense someday in follicular, where you would do an MRD assessment to figure out, okay, can I stop my tazemetostat, or can I stop my PI3 kinase inhibitor? I could see a role for that someday, but it's going to require the right kind of studies telling us how to use it. So for right now, I don't see much of a role for MRD assessment. And then, I haven't been doing next generation sequencing in my relapsed follicular patients, just because we didn't have actionable mutations. Now you have the EZH2. Yeah. So you could make a case to do NGS now. There is also a companion diagnostic that comes with that, where you can just order that specific one. Yes. So I think either of those would be reasonable. to assess the EZH2 status. I don't object to getting NGS sequencing in a relapsed follicular patient. I have no objection to it, but most of the information you're going to get off that panel, you're not going to know what to do with it.
That's true. Anyone else?
Thank you, sir.
Yeah. Yes, Pankaj.
Sir, how you will approach a case of follicular lymphoma patient not responsive to first-line therapy?
Well, fortunately, that doesn't happen very often, but sometimes it does. So let's assume that your first-line treatment is, immunochemotherapy. Then I would think about switching to something that's mechanistically very different. So maybe like R squared, because presumably how lenalidomide kills follicular lymphoma cells mechanistically is very different than DNA damaging agents like CHOP or bendamustine. So I would quickly pivot to something that mechanistically works very differently than chemotherapy.
Thank you. Dr.
And to ask, sir, which subset of patients you want to give CAR T-cell therapy? Is there any subset of patients you want to give CAR T-cell therapy?
Can you repeat that question, please?
Is there a particular subset of patients where CAR T therapy is more?
Got it. Yes. To me, the sweet spot for CAR T cell therapy would be younger patients who have been through two good regimens and are getting disappointing remission lengths. Now the risk of the CAR T is worth it. So I'll make up a scenario, but let's say you had a young patient who was diagnosed with their follicular lymphoma at age 42. Let's say they got BR. Let's say they relapsed 4 years later. Now they're 46. Let's say they get R squared. And let's say they relapse at age 49. Now they're 49 years old. They've had their follicular lymphoma for 7 years. They've been through two of the very best things we have. If you look at what you get from all the traditional options, tazimitastat gets you a year, PI3 kinase gets you 1 year. R-CHOP probably isn't going to get you more than 2 years in a case like that. The traditional treatments are pretty disappointing there. So there's the scenario where I'll say, let's go for it. We'll take the risks on of the neurotoxicity, the CRS. Let's go do CAR T right now. That's the kind of patient that I would steer towards CAR T in 2021.
Thank you. Anyone else?
Sir, if may I ask you?
Yes, please.
Sir, you presented some interesting data on EZ2 inhibitors. So do you advise it irrespective of the mutation status? Because there was patients who were EZ2 negative and showed a response, overall response rate close to 40%.
I would consider tazimitastat regardless of the EZH2 status because it's so well tolerated. If the drug had a lot more toxicity, then I would want to know if it's worth the risk. But it's so well tolerated that I think you could administer it without knowing the EZH2 status.
Thank you. Anyone else? Okay, so we come to an end. I have no words to appreciate your valuable time that you have spent for us. We are together for almost 2 hours. You answered almost 30 questions and 1 hour talk. You really updated each and every one of us, not only the faculty here, but a huge number of audience. Again, not only from India, from number of Asian countries, and even rest of the globe. The patient care will be much superior from tomorrow, and we are grateful to you. The official vote of thanks, we have Paresh to do that.
It was my pleasure. Thank you for having me.
Thank you, Dr. Kahl, for that fantastic presentation. And thank you to all the people who have attended the session. Thank you, Dr. B Agarwal, once again for making Pharmafer part of your academic activity. Thank you, sir. Thank you. Thank you, and good night to all.
Thank you. Good day to you.
Bye.
Thank you. Good night.